Pastor Joshua, can you please confirm that I'm sharing my screen?
Yes, you are.
I can see that. I can see that.
Okay. Okay. Thank you very much, everybody, again. You're welcome to today's webinar. I'll just do a quick introduction of the foundation and welcome you all. On behalf of the chairman and other distinguished trustees of the Rehoboth Dream Solid Foundation, I welcome you to our Q4 webinar. A brief background to the foundation. RDSF was established in 2009 and is currently managed by a board of trustees made up of 9 distinguished and well-accomplished personalities under the chairmanship of Saolade Ndeolushoga Joseph, Rear Admiral retired, CON, MNI, and a former governor of Ogun State. All the trustees are people of integrity, working with one objective: to provide economic empowerment for less privileged people. We achieve this by offering scholarships to indigent students, mentoring young people, providing opportunities for skills acquisition, and supporting the delivery of education. On behalf of the chairman and the other trustees, I want to appreciate all sponsors, partners, patrons, and volunteers. We acknowledge your financial and moral support, and we'd like you to know that without your support, we cannot do what we do. So to every one of you who supports the foundation, we say thank you. Your donations have changed lives and continue to change, and will continue to change lives. Thank you very much. Today's webinar, background to the webinar. In 2018, the foundation introduced a Teachers Excellence Award to recognize and honor teachers in Nigeria. Last year, as part of the event of the 2021 Teachers Excellence Award, we had a webinar where Dr. Barney J. Wilson, an experienced educator, delivered a lecture titled "The Role of Positive Parent-Teacher Communication in Teaching." Today's webinar is in support of the 2022 Teachers Excellence Award, and the theme is mental wealth, understanding mental health and well-being. We're honored today to have as our guest speaker, Dr. Mercy, and to give the opening remarks, Mrs. Omon Aneni Modi. Both women are passionate about mental health and have kindly agreed to work with us to deliver today's webinar. We won't take too much of your time. At the most, we'll be spending 1.5 hours. We would have the main conversation take about 45 minutes, and we'll do a Q&A for 20 minutes. At this time, I would introduce and invite Mrs. Omo Aneni Modi to give our opening remarks to today's event, and just to provide a little background to why she is the person we have invited to give the opening remark. Omo is the founder of Dew Center. It's a wellness center in Lagos. She started her professional career by receiving an LLB in law from the University of Nottingham, England, and further with an LLM petroleum law and policy from the University of Dundee, Scotland. Thereafter, Omo took a diploma in interior design from JJA Academy, UK, which transformed her passion for interior design into a successful business over the past 1.5 decades. Wellness became her mission when she realized that she had all the makings of success, yet she was burnt out and dealing with mental and physical health challenges. Today, Omo is not only an interior and lifestyle design consultant, she is a wellness and mental health advocate. She passionately seeks to boost workplace productivity, relaxation, self-expression, and other desired lifestyle outcomes of individuals and groups through wellness-focused designs, of spaces and experiences. Thank you, Omo. I welcome you now to take over to give your opening remarks, and then we'll take the program forward as the day progresses. If Dr. Mercy comes on, then we'll take our session. Otherwise, you would continue with the conversation. Thank you so much for lending your name at short notice and without reservation to today's webinar. And thank you very much for being one of our financial sponsors. Thank you so much.
It's my absolute pleasure, Ma. Good evening. Thank you for the opportunity. I want to start actually by thanking Rehoboth Foundation for this initiative. I think that it's something that is definitely commendable. It's a conversation that we are not having enough of. Mental illness is, one of the largest problems that we have in our country, and not enough people are identifying it, not enough people are talking about it. And so I want to really thank you for putting this together and being brave enough to, because it's not an easy conversation to have. I've known the Kamala Affairs for years now, many years now, first as their interior designer. And I hope that some of the wonderful things they'll say about me is that I'm hardworking, principled, diligent, high performing. But I don't know if they were aware, they probably were not at the time, maybe only just now realizing that for those years, while I was masking as being successful and high performing, I was also struggling very much with anxiety and depression. And I find that there are so many people in our society today that are suffering in silence. Some are aware of what their conditions are. Some have not been diagnosed. Some just don't know what it is. Some have begun to normalize high, chronic, unhealthy levels of stress and have just accepted it as normal Nigerian life. And this is something, across to bear. But it doesn't have to be that way. Statistics have shown that more than 60 million Nigerians, that's about 1 in 4 Nigerians, suffer from some mental illness. Now, mental illness does not necessarily mean you're crazy or mad. It could be anything from anxiety all the way to more serious cases like schizophrenia, et cetera, et cetera. Only about 10%. So if, I was informed yesterday that over 700 people had registered to attend this webinar. If you add the organizers, let's just call it 800. That means that right here with us now, at least 200 people this evening here have some sort of mental illness, whether they know it or not. That is statistic fact. Only about 10% of these Nigerians are able to access appropriate care, either because they don't know that they need it, they have not yet allowed or given themselves permission to ask for help, or the help is just not within their reach, whether for economic reasons, because it can be quite expensive as well. Another unfortunate fact is that for 200 million Nigerians, there are only 300 professionally trained, licensed psychiatrists to provide this much needed support. As you know now, a lot of our people are even jackpine as well. So that is going to create an even greater problem over the years. Another sad statistic, hopefully I'm going to get a bit happier as we go along, but I just want to really paint the picture so that we are aware of this thing that we're talking about, mental illness, and we can actually stare it in the face and not pretend that it doesn't exist. About 11 people every 100,000 in Nigeria, in Africa, die yearly by suicide. In my own personal social circle, in the last maybe 2 or 3 years, 3 people have died by suicide. All 3 of them were seemingly wealthy, seemingly successful. They were not all adults, 2 were adults. One of them was a student in an Ivy League school who came home on the holidays and just decided he couldn't cope anymore. Now, some of this is in the open, I know, because I know these people, and some of these deaths, unfortunately, will be presented as something else, an accident, or somebody broke in and shot him rather than he shot himself. And we're hiding these stories. We're not talking enough about them, and it's important that we do so that we can address the problem. In the rural areas, mental illness is still viewed as a disease. Mental, illness is viewed as, people being possessed by evil spirits, or is there village people that are doing you? And a lot of people have issues, but they don't accept that there is, clinical help needed. And, we're going to churches or traditional healers, and church is good and it's a beautiful thing, and I will always attest to that. However, if you have a headache or a physical illness, yes, you pray, you lay hands, but you also take your medicine, right? And it's not just in the rural areas. Even in our cities today, people are giving mental illnesses a different name, a different explanation, some euphemism, some other explanation other than what it actually is. Our legislation is outdated and doesn't reflect present realities. So also are a lot of our mindsets. How are you doing today? Oh, I'm well. By God's grace, I'm fine. Are you okay? Oh, I'm very okay. It's still very difficult. It's still very much of a struggle for a lot of us to accept, admit that we are not okay all the time, and that sometimes we do struggle. I don't remember what year it was specifically, but I do remember Nigeria being listed as one of the top 10 happiest places in the world. Nigerians were supposed to be one of the happiest countries in the world. By 2021, we have dropped from 6th place to 114th place. And that is out of 155 countries. So what is it? What has changed? Why are we not happy, right? Mental wellness is not necessarily the absence of stress, just like wellness generally is not necessarily the absence of illness. It's just us not performing optimally, right? Stress is always going to be there. As we say in this part of the world, problem not the finish, right? Stress is always going to be a reality of our everyday life. So what we're not trying to do, in fact, it would be an impossible feat to completely eliminate stress, to completely eliminate triggers or situations or circumstances around us that influence the way that we feel. But what we can do is take control of the situations that we can control. What we can do is equip ourselves with tools and healthy coping mechanisms to deal with these everyday stresses. When I say healthy coping mechanisms, is because a lot of people, and this is not unique to Nigeria, a lot of people cope in unhealthy ways. They cope by drinking, they cope by abusing drugs and substances. They burn the midnight oil, they stay up all night. There's high prevalence of things like insomnia, etc. In Lagosians cope by partying and forgetting their sorrows. You're going to go back home and those issues are still going to be there, however you want to try and escape them, right? So getting help for your mind, let's just put it that way, is equipping yourselves with tools, with resources, with the knowledge, with the understanding, with the support that will help you better cope with life and better contribute to your society, as I'm sure we all would like to. Now, mental health is not a respecter of people, of nations, of socioeconomic class, of gender, of age, of profession. It's something that affects potentially absolutely every demographic, right? As I mentioned earlier, 1 in 4 Nigerians, so you can't even just say it's the upper class or the lower class or the north or the south, or it's across the nation, it's across the continent, it's across the world. Teachers, for instance, you could pick any profession. Teachers, for instance, I can only imagine the levels of stress that they go through on a daily basis, right? So you have your own personal issues that you're dealing with at home, and then you're in a position where you're responsible for impacting knowledge and, improving the lives of so many people you deal with on a daily basis. They come, they go, and each person has different needs. These needs are sometimes really draining on teachers on a daily basis. I know that I hear that the profession can be extremely gratifying in the long run. So maybe you've had a student who's now successful, they've come back and said thank you, and in that moment you feel, okay, this is worth it for me. But on a daily basis, it's absolutely challenging. And I can only imagine, in doing my preparations for today's talk, I came across something I'd never heard of before, which was teachers burnout. So apparently there's a specific brand of burnout that is unique to teachers, and this is because of the demands on them on a daily basis. Students, for instance, they face lots of academic pressures, whether it's high school students or university students. There are high levels of peer pressure. You're having pressure from your colleagues and contemporaries. You're having pressures from home, emotional challenges, right? Schools, as young as primary school, that is where a lot of people for the very first time are exposed to things like drugs and alcohol. And so the pressures of, let's try it, and, the impact that has on in the long term. That is the first time that people are exposed to unhealthy coping habits that are presented as if they are not just normal, but actually expected of you. I remember when I went to Queen's College, and when it's lights out, I go and sleep, or I don't care if I have an exam tomorrow. But then my mates will be looking at me like, what? You're going to sleep? You're not going to cram all night? As if that should be the norm as opposed to the exception. And there's almost a feeling of guilt that if you're actually sleeping well and eating well, it's like there's something wrong with you. You should be cramming. You should be. I remember by the time I got to university, there was some caffeine tablets that, my friends were sharing, and nobody thought of it as drug abuse. No, it's just tablets to help you stay up at night so you can read for your exams and do well. And these little normalizations of unhealthy behaviors, unhealthy practices, unhealthy dependencies definitely have add-on, knock-on effects, and cause people to struggle and not be able to cope in a healthy way with everyday stress. Another thing that I now am aware, just because of my personal experience in the mental health space, that I'm now aware of, is that even young children, young people, have struggles that people, grown-ups, let's call us grown-ups, don't acknowledge. They think, what's your problem? You're not parents. So how can you say you're stressed? How can you say you're under pressure? My friend, go and read your books. That's all you have to do here. Go and read your books. But actually, the go and read your books in and of itself is a pressure. The expectations from your parents that you better not come home with anything more or less than top 3 in your class, because the other ones, do they have 2 heads? That in itself is a pressure, and it starts from an early age and continues into adulthood. So as grown-ups, we are now expected to always be high-performing, to always be, working hard and hustling, to always be providing, to always be a support system, and to not ever admit that you're not at your best. It's seen as a sign of weakness, and it then breeds a vicious, unhealthy cycle, because the more you're pressured, the more you don't ask for help, the more you're pressured, and on and on and on and on.
Thank you so very much.
Any profession at all absolutely is affected. I just want to close by saying that in the last couple of years, post-COVID, I always refer to the lockdown months as a blessing, a curse, yes, but also a huge blessing, because on the one hand, it created circumstances that were more stressful for people, more people dealing with anxiety. They're not sure what's going to happen tomorrow, etc. But what it also did for us is that it brought the conversation about mental health to the forefront. It brought, for the first time, more help, more support, more tools, both online and in person, more resources closer to people who actually need it. So I think that is the beginning of what I hope is a more positive outlook for the average Nigerian. And I hope that together, starting with conversations such as today's webinar, I'm really looking forward to what Dr. Marcy is going to share with us, but I'm hoping that together we can, curb this crisis, as it were, so that it doesn't spiral out of our control. Thank you again for the opportunity.
Thank you so very much, Omon. Thank you very much for speaking to us from your heart. And when we get to the Q&A session, I hope that you will still be with us. And some questions, you may have to address some questions, being a Nigerian who has, received help in the past for mental wellness. Thank you very much, Omon. You know what I mean. Thank you so much. Dr. Mercy, thank you for joining us. I would now happily introduce you and let you have the floor. Thank you very much to all the officers around the call. We have some very senior officers, some 2-star generals, 1-star generals. Thank you for supporting Mr. Chairman. The chairman of the foundation is a retired military officer, and so I know some of his friends are around the call, and also one of our trustees. Dr. Mercy is she is an associate dean. She is the associate dean for students and a tenured professor of psychiatry at the University of Central Florida College of Medicine. She is a distinguished fellow of the American Psychiatric Association and the Association for Academic Psychiatry. And she is a fellow of the American College of Psychiatrists, where she also serves on the Board of Regents as an officer. She also, like Omon, willingly, without hesitation, collaborated or agreed to collaborate with us to bring today's session. Thank you so much, Dr. Mercy. You have the floor, and we will take questions after your session.
Thank you so much. I want to start by just thanking the foundation. I want to thank all of the trustees, and I especially want to thank Admiral Komalafe and Mrs. Komalafe for the invitation. It is truly my honor and privilege to have the opportunity to speak with all of you today. And thank you, Aman, for the introduction and the opening remarks. I'm going to share my screen and use this as a guide for our conversation today. So I want to start, we're going to be talking today about mental health. And I think many of us take mental health for granted. When we have good mental health, we are just, going along with life and just thinking, oh, everything is fine. And it's only when we lack good mental health that we really start to pay attention to it. So much of my talk today is going to actually be about mental illness and how we can get back to a state of mental health, or how we can take proactive steps to maintain our mental health. And so I'd like to start by really sharing sort of the scope of the problem. While mental health has always been an important issue for us to be aware of, I think the COVID pandemic has really brought to light how serious some of these problems were. Certainly the pandemic, with lockdowns and restrictions, with anxiety about our own health, anxiety and fear about the health of our loved ones, or perhaps grief and loss from loved ones who succumbed to the illness. Certainly, those stressors were kind of the perfect storm to lead to development of new mental health symptoms that perhaps people had never experienced before. But also, the COVID pandemic with the isolation may have led us to have some recognition about our own mental health problems, perhaps for the first time. And I like to start with this graph because this shows you that prior to COVID, looking at typically some US and European countries, the blue bars represent the rough estimates of what several mental health challenges looked like prior to the pandemic: depression, anxiety, overall distress, and sleeping problems. The orange bar shows you what it looked like when the pandemic hit. And so you really see us skyrocketing across the board in terms of worsening mental health. And so I think this is very relevant for the current space that we are in. Sometimes I think the best way to understand something is to understand what it's not. So before I define what mental illness is, I think we should start with what mental illness is not. And I want to be very clear that mental illness is not something that is all in your head. It is not a moral failing. It's not simple laziness. It's not a lack of faith. I hear that often. It's not sin, and it's not something that you can just get over any more than you can just get over another medical problem. What it is a real brain disease. Your brain is an organ, and it can become diseased just like any other organ in your body. Mental illness results in significant changes in the way you perceive the world and the way you interact with the world. And although it is very treatable, it can also be very disabling if left untreated. So when I talk about mental illness, I like to use an analogy to diabetes. And when I'm talking about diabetes, I hope that we're all familiar with this, but just to be clear, talking about type 2 or adult onset diabetes. This is the diabetes that people tend to get when maybe their diet isn't the healthiest, they may be a little bit overweight, or their weight's not where it should be, or maybe they're not able to exercise. This type of diabetes we know arises from an interaction between our genes and our environment, and those two things together lead to the disease. So what do I mean by that? Your genes, your genetic predisposition, which is a fancy doctor way of saying your family history. So we know that people who tend to develop diabetes usually have a family history of it. It usually is something that runs in their family. So when they have that genetic history, and then they also encounter maybe not eating well, their weight getting too high, gaining too much weight, or perhaps not exercising well, those two things together lead to the disease diabetes. And what we know is that many psychiatric disorders, many mental health conditions are similar. If we take depression as an example, we know that depression runs in families. We know that there is a genetic predisposition to developing depression. Even children who were born to parents with depression and are adopted and raised in an environment where there is no depression have an increased likelihood of developing depression. So we know there's a genetic risk. If you have that genetic risk and you encounter certain environmental stressors like loss, early childhood trauma, significant, stress and isolation, those two things, the genetic risk and those environmental factors, can interact together to lead to the disease, the brain disease, depression. Now, you might imagine a situation where someone with diabetes has such a strong family history, such strong genetic loading or genetic risk for diabetes, that even if they keep their diet healthy and their weight is good and they're exercising, their genetic risk might be so great that they still develop the disease diabetes. And that can be true with some mental health concerns as well. Maybe you have such a strong genetic risk of depression, that even in the absence of those environmental risk factors, you might develop it. Or the opposite. You might have someone who has a very low genetic risk for diabetes, but with enough bad environmental stressors in their life, if their diet is bad enough, if their weight is out of control enough, or if they are really not, struggle with their physical activity, they might develop diabetes. And the same is true with things like depression. Even without a genetic risk, if you have enough loss, enough isolation, enough trauma, enough stress, you might find yourself developing the brain disease of depression. And what I want you to hear, and I hope every one of you will take away from this, is that it does not matter if it's your pancreas, which is the organ involved with regulating your blood sugar, or if it's your brain. You have no more control over your organ developing a disease when it's your brain than you do if it's your pancreas developing a disease, right? Somebody with diabetes can't just say, pancreas, make more insulin and control my blood sugar better. And somebody with depression can't just tell their brain to not be depressed. It doesn't work that way. If you think about how our organs work, picture the heart. The heart is responsible for pumping blood to the rest of the body. If the heart gets diseased, it struggles to pump the blood well. And what you start to see when people have a condition that affects their heart is you see impact because the heart's function is impacted. When somebody has brain disease, it's going to affect the things that the brain does. It can affect our motor and sensory behavior, like when someone has a stroke. But the other thing the brain does is it thinks and it feels. And so when we get brain disease, it can also affect how we think and how we feel. So this is a disease, a physical disease, just like any other condition. And I want you to really hear me that depression is a real disorder with biological changes. So besides just feeling sad, depressed patients have whole body symptoms. They have an increase in their stress hormone levels, cortisol. It impacts their sleep. It affects biological symptoms like sleep and appetite. It changes the neurotransmitters in their brain, and it even impacts their immune system, which is what your body uses to fight off infection. So it has a whole body effect. Okay. And this is about as sciencey as I'm going to get on you, but this is a picture of a PET scan. What a PET scan does is measure the brain activity. And in the picture that is labeled healthy right here, what you can see is a lot of bright colors. Those bright colors represent normal activity, lots of activity happening. The brain that is labeled MDD, that's our medical abbreviation for depression. It stands for major depressive disorder. You see more subdued colors. So there's less activity happening in the brain. So even when we look at brain images, when we're looking at brain function and blood flow, oxygen use, that kind of thing, you can see a difference. And so this is a real brain disease. Now, when we define psychiatric disorders, we use something called the DSM-5. That is the book that really provides a common language for physicians and mental health providers to talk about mental health conditions. It outlines the kinds of symptoms and how many a person needs to have in order to be diagnosed with a condition. And what you'll find if you ever look at the DSM-5 is that most psychiatric disorders, an essential feature of them is that it causes significant distress or impairment in their life. And I emphasize that because it is normal to have different emotions, right? We're supposed to have sadness at times. If someone dies, we are supposed to grieve. There's times that it's appropriate to feel anxious about something. But when it begins to impact our ability to function in our life, that's when it moves into the disorder. So when I'm talking with patients or when I'm educating students in psychiatry, I like to draw this graph. And what you'll see on the vertical axis are feelings of happiness above the horizontal line and feeling sadness of below. Now, no one's mood should be flat. We are not robots. We are not supposed to have the exact same emotion every single day. In fact, our brain is kind of wired to detect differences. So I've drawn a rough estimate of what a normal mood might look like. So you have good days and you have bad days. You have days where you're happier and days where things just don't quite go your way and your mood goes up and down, and that's what we would expect. I would call normal sadness these periods that dip below the line, but then recover quickly. When we think about depression, I think of this red line where you see a period of abnormal intensity with the sadness. So it's more intense sadness and it's more persistent. Now, in reality, this line probably goes up and down here too, right? Because even when you're depressed, you have better days and worse days. But that is what depression tends to look like, okay? So what I would like to spend some time doing today is overview 4 fairly common mental health conditions that I think you probably are likely to know someone who experiences because they're fairly common, or maybe you yourself might feel like you've struggled with this, or you might recognize some of these symptoms in yourself. And so I just want to make you familiar with what these conditions look like. And then we'll talk a little bit about treatment and how to prevent mental health problems. So the first condition that I want to talk about is major depressive disorder. And this is a period, like I just showed you, where your mood is very low. Typically, we think of feeling sad or blue or crying, but it doesn't have to be feeling sad. You can also be diagnosed with major depressive disorder if you simply just no longer enjoy life like you used to. So maybe, I don't know, maybe you used to love fishing, and all of a sudden, when you are going to fish, it just doesn't bring you any joy. You don't find any happiness in it. You can have both of those or just one. The symptoms have to be present most of the day, nearly every day for at least 2 weeks. So we're talking about an extended time period. And most of the time when people have depression, at least in my experience, it's much longer than that. And it's associated with other symptoms. Typically, people have difficulty concentrating. They might feel guilty about what they're doing or what they're not doing, or feel like they're not worthwhile. They might feel hopeless or like there's no hope for the future. It affects biological activities like their sleep and their appetite, their energy level. And most concerningly, people can even have suicidal thoughts. They can start to feel like life's not worth living, think that maybe things would be better off without them, or even think about ending their own life. And so again, I want you to hear that this is different than normal sadness. This is a very whole body kind of disorder. It's sadness plus all these other biological symptoms impacting concentration, sleep, appetite, energy, and physical activity. Okay. Now, generally, it's not enough just to have depressed mood or decreased enjoyment of life. You have to have several of these symptoms as well. And as I mentioned, it interferes with your daily functioning. The next, I want to talk about a kind of anxiety called generalized anxiety disorder. And this is the kind of anxiety that presents with people who kind of worry excessively or have this general feeling of apprehension about everyday things. Often when I'm seeing patients who have this kind of disorder, they'll tell me that they are known as the worrier in their family or among their friends. They might even find themselves worrying if there's nothing to worry about because they're thinking, oh my gosh, I don't have anything to worry about. What have I missed? There must be something I should be worrying about right now. And it's this feeling that even if there was a real thing that they should be worried about, somehow they're worrying about it even more. And again, this anxiety is present more days than not over at least several months, and it tends to be associated with other problems. They often get tension in here or tightness in their jaw, clenching of their teeth, tension headaches. They feel very restless. It's hard for them to relax. They feel like they can't sit still. They always have to be doing something. They may get physical symptoms of anxiety, their heart palpitating, sweating, shakiness, that kind of thing, feeling on edge or nervous all the time. And again, we see some impact on biological functions. It can affect sleep. It can affect your ability to concentrate, and it may even cause you to have low frustration tolerance or be irritable, maybe with other people or maybe just with yourself. Maybe you're just very short-tempered and frustrated with yourself. And again, it gets to the point where it's starting to interfere with your daily life. You just can't relax. You just can't sleep. You can't stop worrying. And interestingly, no matter how hard they try to stop worrying, it's beyond their control. They can tell themselves don't worry about it, but the worry just keeps coming back. And that's, again, how you know it has reached kind of a disorder level, because they're not able to control it. There's another kind of anxiety called panic disorder. And this is a kind of anxiety that is a little different. There's several different kinds of anxiety. I'm just going to touch on two of them today. So this is the kind of anxiety that typically involves having recurrent panic attacks, sometimes triggered by a stressful event, but often they just come out of the blue. You're just going about your daily business and all of a sudden you're having a panic attack. Now, I want to be clear that just having one or two or even a couple panic attacks does not mean you have panic disorder. Panic disorder is when you have recurrent panic attacks, so they happen over and over, but you also start to find yourself worrying or anticipating having future panic attacks or what those panic attacks mean. Or you might even start to change your behavior so that you don't have an attack. Like, oh my goodness, the last time I had a panic attack, I was in the car, so I'm not going to ride in a car anymore because I don't want to have a panic attack. Or the last time I was in a grocery store, I don't want to be in a grocery store because I'm afraid I'll have a panic attack. And again, it interferes with your daily functioning. Certainly, if you're changing your behavior to prevent having future attacks, that interferes with daily functioning. And I want to give you some example of what panic attack symptoms are like. Often it feels like having a heart attack. And sometimes that's really an important thing to distinguish. You might have a racing heart or chest palpitations, chest tightness, feel sweaty, trembling, feel like it's hard to catch your breath. Sometimes people feel like a choking sensation or almost like a lump in their throat, like they can't swallow, might have upset stomach or dizziness. You might get really cold and feel like you have the chills or feel like your face gets flushed. Not always, but sometimes people get tingling in their fingers or sometimes around their mouth. They may feel like life isn't even real right now. They're not sure what's going on. And often, as it's happening, they think, oh my gosh, am I going to die? Am I having a heart attack or am I going crazy? And it's very, very distressing. Now, typically a panic attack comes on very quickly and it usually lasts most of the time 15 to 20 minutes before it goes away. Sometimes a little longer than that, but that's pretty typical. And so when you have those recurrently and you start to change your behavior because of them, that is called panic disorder. And the last condition that I want to talk about is called post-traumatic stress disorder, or we call that PTSD. Now, this happens when you have an exposure to a significant trauma. Now, I don't know if this happens in Nigeria, but I can tell you that it happens in America. We have I guess the best word is we've misappropriated the word trauma, and we describe a lot of things as traumatic that really are not traumatic. I have a teenage daughter, she's 14. She describes all kinds of things as traumatic. You know, I got a B on my test at school today, and I was traumatized by it. That's a bad day. That's not trauma, right? And so I think when we misappropriate the term trauma for things that are really not as severe, as life-threatening, as traumas that other people experience, I think we minimize what that experience has been for them. And I think that does them a disservice. So when I talk about trauma, when we talk about it in psychiatry, what we're really meaning are generally life-threatening traumas. These might have happened maybe when they were a child, they were abused physically, sexually, or even emotionally, because as a child, that is life-threatening to you. It might have been a combat experience in the military. That is certainly life-threatening. It could have been a severe car accident that you witnessed someone killed, or that you were in and were afraid that you were going to die. But that is the kind of trauma that we are talking about. In response to that trauma, just having trauma does not mean you develop PTSD. Remember, genes and environment equals disease. So you might have the trauma, the environment, but maybe you might not develop the disease. So in response to that trauma, you see other symptoms. The ICD-11 classifies them in 3 categories. The DSM-5 puts them in 4, but just for the sake of simplicity, I've summarized them here as re-experiencing symptoms. That's when you find yourself having intrusive memories. You don't want to think about the trauma, but it keeps coming back over and over, or you're having nightmares about it. Or when you're exposed to a reminder, you find yourself very afraid again, or even getting those physiological symptoms of anxiety like sweating or shaking or your heart racing. You find yourself trying to avoid people, places, events, reminders, thoughts of the event because you don't want to deal with it. And then you experience symptoms kind of always being in heightened threat. I've treated a lot of people with post-traumatic stress disorder, and they find that they startle really easy. If someone comes up behind them, they startle way more than the average person, or they might be that person who's always aware of their surroundings. They need to have their back against the wall. They tend to not sleep well. They tend to be irritable, and they tend to struggle with concentration. And again, it interferes with their daily functioning. That is something that is a recurrent theme, okay? So we've talked now about depression, about general anxiety, about post-traumatic stress disorder, and about panic disorder. And I think it's really important for us to talk about, when does it become a disorder? Because I mentioned to you that we are not robots. We were created to have emotions. We are supposed to feel sad when we experience loss. When something wonderful happens, we're supposed to be happy. I can tell you that anxiety does a good job for us at times, right? Those fight or flight symptoms, which is what you experience in a panic attack, right? The heart racing, all of those things happening, getting nervous. Those things are supposed to happen when we're in danger. If I'm in the woods and a big bear is chasing me, I need my heart to pump faster to get blood to my muscles so I can run, right? Otherwise, I'm in danger. It becomes a disorder when that panic attack is happening when I'm not really in danger, right? I can tell you, when I'm anxious and I'm worried about an exam when I was in medical school, I sure did better on it because I prepared more. So all of these things are there for a purpose, but it becomes a disorder when the intensity becomes greater. Remember that graph I showed you where the normal mood range was here and depression drops down. So when the intensity is greater, that might be a signal that we're moving into disorder territory. When it's persistent, when it lasts longer than we would expect a normal mood to last. And when you see associated symptoms, like those biological symptoms, bodily symptoms of sleep problems, appetite problems, energy, concentration problems, and when it begins to impact your ability to do your job, take care of your family, go to school, do the things that you need to do. The other way that I would think about it is when normal coping strategies are no longer working, we might be moving into disorder territory, right? So if you normally would handle stress by going for a run, and now you're running twice a day, every day, and you can't get your anxiety or your mood to respond, that tells you that there might be something more serious going on. So we talked about diabetes and how genes and environment equals disease, and it's the same thing for many psychiatric disorders. I want us to use that same analogy as we talk about treatment. So for diabetes, when we talk about treatment, I generally think about it involving behavior change and sometimes medication, okay? So what do I mean by that? If you develop diabetes, generally the first thing that the doctor is going to recommend you try is losing weight, eating healthier, and starting to exercise. And sometimes that behavior change is enough to get your blood sugar back under control. Sometimes it's not, and you need to add medication in. Or sometimes, for whatever reason, just your life circumstances, you're not able to do all those things. It's too difficult for you to find the time to exercise or to change your diet. And in that case, you might say, I'm just going to go with medication because I know that that works. Well, it's very similar for psychiatric and mental health problems. So let's take depression as an example. The behavior change that we use would be what we call talk therapy, psychotherapy. We know it's very effective for treating depression. And sometimes that's enough. Sometimes you need the talk therapy plus medication for the brain disorder. And sometimes the talk therapy is not accessible depending on where you live, or it's not affordable, or for whatever reason you can't do it. And sometimes then you just go with the medication treatment. So just like we don't have a stigma around treating diabetes, right? If somebody needs treatment for their diabetes, or if somebody has a heart condition and they have to take medicine or go to therapy for their heart condition, we don't place judgment on them. We don't, stop for a second. We say, please take what you need. And, just as we do that, I think we need to do the same when we have a brain disorder. There shouldn't be a stigma around treating your brain to get it to function like it was intended to function. Now, as we talk about treatment, I want to start first with what doesn't work. Just telling somebody to cheer up or to just get over it, that does not help. Telling somebody that things could be worse, often that makes people feel even worse. They think, oh my gosh, you're right. Things are much worse for my neighbor or my friend. Why am I feeling so bad then? What's wrong with me? So that actually just kind of worsens the depression. Or telling people, why are you worrying about that? They don't want to be worrying about it. If they could stop, they would. If they could just relax, they would. And importantly, sometimes even using helpful words, sometimes using scripture, sometimes, an inspirational quote, whatever it is that you want to suggest, even that can be interpreted through the distorted lens of guilt, shame, and worry, right? Once your brain has a disorder, whatever disorder it is, it impacts how you think and how you feel. So sometimes we have sort of a distorted lens that we're viewing things through. And so that's not always helpful. So I want to start first with talk therapy or psychotherapy. I'm going to just share this briefly. There are many different kinds of talk therapy. I've listed some of them here. They're typically done one-on-one, but you can certainly do talk therapy with a group or as a couple or in a family. And the things that, in my opinion, are of most importance are having good rapport with the therapist and trust. You need to feel like like you can trust them, that they understand you, that you can talk with them. You need to go consistently, and you need to be willing to put in the difficult work to work through challenges, because it's not easy. Let me give you an analogy. And I'm going to give you this analogy because I often have patients say to me, but doc, I don't want to pay to go talk to someone. I don't want to pay for talk therapy because I have friends. Why can't I just go talk to my friends? Well, let me ask you a rhetorical question. I want you to imagine that you have a shoulder injury. You've damaged your shoulder, you've fallen on it, or you've injured it. And what the doctor is recommending is that you go to physiotherapy, or over here we call that rehab or physical therapy. Okay. So you go to do some rehabilitation of it. And your doctor is recommending that because he or she knows that physiotherapy is using scientific knowledge to apply exercises that are going to restore function and bring healing. You're not going to just go talk to your neighbor down the street who has no special training and say, hey, what exercises do you think I should do for my shoulder, right? You're going to go ask an expert who knows how to restore function and bring healing. And with talk therapy, it is much more than just talking to a friend. It is a specific scientific medical intervention that was designed to restore function and bring healing, okay? Just like with physiotherapy, if you only went once every 2 to 3 months, your shoulder is not going to improve. You have to go regularly and do the exercises regularly. It's the same thing with talk therapy. And I have been through physiotherapy. I will tell you that sometimes it hurts, right? If you don't ever have the pain of working through that injury, it's not going to get well. And when we're doing talk therapy, sometimes it's painful. It's emotionally painful, and we have to be willing to work through it. So I think hopefully you understand now how important and how important I think that is, that we be open-minded to that, just as with physical kinds of therapy. And I want to share one type of therapy with you to give you an example of how it works. This is an example of cognitive behavioral therapy, or we call that CBT. Now, in cognitive behavioral therapy, it's based on the understanding that our thoughts, our behaviors, and our feelings are linked to each other, and each influences the other. So if we lay around all day and don't do anything, we tend to think more negative thoughts and feel lower. If we have negative thoughts, that affects our emotions, and we tend to not want to do as much, right? So you get what I'm saying. Each of these affects the other. But interestingly, the way we're created, the way we are wired, we only have direct control over 2 of these. We cannot control our feelings directly. We can only directly control our thoughts and our behaviors. And if you question me on this, if you want to doubt me on this, I want you to imagine, instead of an emotional feeling, imagine a physical feeling. Imagine hitting your thumb with a hammer, right? Or stubbing your toe, slamming your hand in a door. Can you just say, stop hurting, and have that work? No. So you don't have direct control over your feelings. And once you've reached disorder level with depression or anxiety or those kinds of things, you can't just say, stop feeling sad, stop feeling anxious. But in cognitive behavioral therapy, the therapist works with you to change your thoughts and your behaviors, which ends up changing your feelings. So let me give you an example for anxiety. We know that all of us, every single one of us, every day make cognitive or thinking errors that we're not even aware of. And most of the time, they're of no consequence to us. But if we have depression or anxiety, we tend to make a couple of the same thought errors over and over and over. So if you were working with a CBT therapist and had a lot of anxiety, they might point out to you, this is an example of catastrophizing. Let me give you an example. It might be, if I had catastrophizing, let's say I tried to call my husband on his mobile phone and he didn't answer. And I might jump immediately to the conclusion that he must have been in a car accident and is dead, right? That's an example of catastrophizing. You jump to the worst possible outcome. And so the talk therapist would say to me, Marcy, you are catastrophizing, and then would teach me how to challenge that. And so an example, there are many ways to challenge it, but one example might be, what are other possibilities for why he's not answering his phone? And I could say, maybe he left it in the car. Maybe it's on silent. Maybe he's just busy talking to someone. Maybe he didn't hear it. There's all kinds of other reasons why he might not have answered his phone. And that brings my anxiety level down. And so that begins to help me feel better. And they teach you how to do that. And the fascinating thing about CBT is that it actually causes changes to the brain. So these are some MRI studies. And all I want you to focus on is that there's some regions where there's yellow and blue. And that shows you changes to parts of your brain in terms of volume. It actually changed the volume of your brain in response to psychotherapy. So this is far more than just talking to a friend. It's a real medical intervention that actually changes how your brain functions, okay? Now, I do want to say a word about medication as a psychiatrist. I'm trained as a physician. And for the 4 conditions that we talked about, most of the time we are going to use a class of medicines called antidepressants. There are some others that you can use if needed, but typically we talk about the antidepressants. Now, what often happens is people don't realize how these work. It's not like taking a pain pill where you take it and should feel better right away. It doesn't work that way. You start taking it, and it usually takes at least 4 to 6 weeks to reach full effectiveness. You might start feeling a little better within the first couple of weeks, but you won't feel the full benefit until you've taken it for at least 4 to 6 weeks. And if you've ever taken like an antibiotic for an infection, you know that you can't just take a few doses until you feel better and stop, or the infection will come back. You have to finish the course of treatment for you to really be well. And it's the same thing with these medications. You need to take it for an extended period of time to do well, not just till you feel better. If you stop taking it once you feel better, you'll get sick again. And so, for example, with depression, it's usually at least 6 to 9 months, and there are certain circumstances where people might need to take it even longer. Overall, they're very safe, very well tolerated. The biggest question I'm usually asked by patients is this going to change my personality? Is it going to make me into a zombie or kind of like zoned out or that kind of thing? And my answer is no. If you take a medicine that does any of those things, that makes you feel like a zombie or feel like you're not your normal self, I usually tell my patients, let's try something different because I don't want you to feel that way. What the medication should do is remove the symptoms so that your natural personality can shine through. It just takes the symptoms away, but it doesn't change who you are. Just like taking insulin for diabetes doesn't change who you are. It just puts your blood sugar back to normal. Okay. I do want to touch base on when you should refer someone, and because you may encounter somebody that you think needs help, and how do you know how urgent it is? Well, emergent help is needed if someone is feeling suicidal or is expressing any concern that they may not want to go on living or may hurt someone else. We take all of those things very seriously. We immediately, you don't want to make a mistake of minimizing somebody's expression of feeling suicidal and then have them actually end their life. So you take any of those things seriously and get them help right away. If they're no longer able to take care of themselves, if they are hearing voices or hallucinating or experiencing any other symptoms that suggest that they are not in touch with the reality of what's happening around them, or certain drug or alcohol intoxication and withdrawal states can be life-threatening and they need emergent help. Other signs that help is needed is when old coping mechanisms aren't working or are starting to become excessive. If there's an intensity or a significant change in your mood or behavior that's persistent, if it starts to affect your day-to-day functioning, if it starts to affect your biological functions, or if you start to experience suffering, then certainly help is needed. And I really want to emphasize that there is no shame in going to get treatment, just like there should be no shame in going to get treatment for diabetes or high blood pressure or heart condition. I hope that what you leave from this session, that you recognize there is no shame in getting treatment for any organ in your body, including your brain. I do want to spend just a couple minutes talking about something called burnout. Burnout is not a true psychiatric diagnosis, but it is a syndrome that we see. And I don't know if this happens in Nigeria, but in America, people talk about this all the time. Oh, I feel so burned out. Burnout is a syndrome of feeling emotionally depleted, like you have nothing left to give, feeling kind of detached from your work and from your loved ones, and feeling this low sense of personal achievement. Like no matter what you do, it's just not good enough, and you're just not able to accomplish what you need to accomplish. And burnout tends to develop when there's very high stress and your ability to control that stress is low. You can imagine a lot of situations that might look like that, but certainly the pandemic, right? We had a lot of stress, a lot of fear and anxiety about health, about our loved ones, and very little control over that situation. So it was the perfect setup for people to develop burnout. And what we know about burnout is that when people develop it and don't address it, if left untreated or left unchecked, it can go on to turn into other things like depression or anxiety. Okay. Now, there are certain characteristics that it can increase your risk of developing burnout, and I've listed them here. I'm not going to read through them all. You can see them here. I just encourage you to look through this list and ask yourself which you might have. No shame in this. I'm going to tell you, these are present. I work a lot with physicians and with medical students, and most of us have a lot of these. Many of these are actually good things. They just increase your risk of burnout, right? You can imagine a surgeon who is doing life-threatening, life or death surgery needs to be able to suppress his or her feelings, right? If they're constantly thinking, oh my gosh, this person's life is in my hands, they're going to be shaky and worried about it, right? Perfectionism. I can tell you, if I'm having surgery, I want my surgeon to be a perfectionist. I want the surgery to be done well, right? So these are good things, but they do also put us in a situation where we may be more likely to experience burnout. So I would like to wrap up my speaking points today by talking about strategies for prevention, for preventing burnout, and just for being proactive about good mental health overall. And I'm going to give you all a little assignment to do, a very short assignment. I am a university professor, so I can't do a talk without giving you something to really apply it. It's ingrained in me. I've been a professor too long. So I want you to think about these and how you might see these applying to your life. So the first one are spiritual practices. This could be reading the word. It could be worship. It could be Sabbath. It could be engaging, attending religious ceremonies, whatever they are for you. Engaging in spiritual practices, we know, are preventative towards mental health problems and help engage people in support. Personal boundaries and downtime. So for some of you, you may have a hard time saying no. And maybe you need to be a little bit better at saying no to some things. Maybe you just need to give yourself a little bit of downtime. I know for me, if I can have just a few minutes at the end of the day, in an ideal world, I'd have 30 to 60 minutes to myself just to kind of come down from my workday and relax a little bit. But I have a family, I have children, I have a husband. I don't have a lot of downtime at home. So even 10 minutes to myself where I can process what the day has been like helps me a lot. And being good about personal boundaries. Delegation. Maybe you're doing everything and there might be some things that aren't as important for you to do. Maybe there's somebody in your family or somebody in your work environment that you can say, hey, could you help out with this, even if it's for a short period of time? And they may even get benefit from it. They may be delighted to help you. Maybe they were looking for an opportunity to grow. And that will help you by getting something off your plate and will give them an opportunity for their own growth. This is a practice the next one is a practice that I love to do. It's called intentional gratitude. And it is a practice of taking time to give thanks and be grateful for good things in your life, even when things are difficult. And we know that this not only improves mental health and helps with anxiety and sleep and mood, but it also helps with physical symptoms. It helps reduce pain. It's been shown to help with blood pressure and all kinds of other physical symptoms. And the way that I do this, I have a little journal. I just write down the date and 3 things I'm thankful for. And my goal is to not write the same 3 things every day because that becomes meaningless. And certainly I'm thankful for my family every day. I'm thankful for my church. There are things I'm always thankful for. But if I write those same 3 things, it's not always the same. And so it's not as meaningful for me. So some days it's big things, like I'm so grateful for, opportunities. This morning, I actually wrote that I was grateful for the opportunity to speak to all of you in Nigeria. And I'm grateful for the technology that allows us to do this. Some days I'm really tired. And I'm grateful for a cup of coffee in the morning. And that's the best I can do. But by starting with an attitude of thankfulness, it puts you in a better state of mind for whatever you face during the day. Sleep is really important. And I don't know how it is for you all, but I can tell you that in America, we are sleep deprived, and we also often stay up not for any good reason. We need to give ourselves enough time to sleep, and most human beings do best when they have 7 to 8 hours of sleep. Some people need more, some can get away with less, but I encourage you to, more days than not, try to give yourself enough time to sleep. I know emergencies happen, things happen, but most of the time you need to give yourself enough rest. You need to be aware of what you're putting in your body. I would never put sugar in my car's gas tank and think it would run well. And yet I think so often we put bad food into our bodies and then expect our bodies to run well. Now, please hear me clearly. A good piece of chocolate or chocolate cake, that is good for my mental health sometimes. Sometimes that is just what I need. I love chocolate, but if I do that every day, then that's probably not going to be in my best interest. So putting good food into my body. I think finding time for exercise, and this doesn't have to be, intense. It could just be going for a 10-minute walk, or spending a little time outdoors is really good for you. When I spend so much of my time looking at a computer screen, if I can take a 10-minute break and walk outside, see the trees, feel the wind on my face, hear the birds singing, just feel the sunshine, it reminds me that there's a bigger world than the problems that I am trying to solve on my computer. And that's good for me. Working hard on being present in the moment. It's popularly called mindfulness right now, but the idea is, if you're speaking to someone, focusing on what they're saying so that you're not thinking about all the things you have to do in the future or worrying about all the things that have happened to you. So working on trying to be present in the moment. Here's another one that I love, and I'm going to teach you all how to do it now. Deep and intentional breathing. There's a specific way that if you practice this breathing, it becomes more natural for you to do, and it actually physiologically changes your body to put you in a more relaxed state. And the more you practice it, just like any skill, the better you'll get at it. This kind of breathing involves taking an inhale, taking the breath in through your nose, holding it briefly, and then exhaling slower through your mouth. You can do it in any way you want, but I like to call it a 4-7-8 breath. So what you would do is you breathe in through your nose for a count of 4. You hold it for 7. And then out slowly through your mouth for 8. And when you do that, you find physiologically your body goes into a more relaxed state. You can do a couple of those in a row. One reason I love it is it doesn't matter if you're in a group or alone. People don't even realize you're doing it. You just do it quietly. You can do it if you wake up at night and can't sleep. You can do it first thing in the morning. You can do it before you go to bed. It's a great practice to develop. Another thing that's incredibly useful in preventing burnout is finding meaning in your work. And maybe you love your job, but you've gotten so caught up in all the details and the day-to-day grind that you forget why you're doing it. I'm not a journaler. I don't like to write a lot. My journal is literally just the 3 things I'm grateful for. I find my mind just goes faster than I can write, but I do like to combine downtime with walking outside and reflecting on why I do what I do. And that helps me to find meaning. I also think shared experience is critical. Finding someone who understands what you do, whether it's at the same stages you are in school, the same kind of job, similar family situation, that you can both talk through what you're experiencing, because it reminds you that you're not alone, that you're not the only one experiencing that. And I have a good friend who's a psychiatrist that I speak with about once a week, and we share our experiences together. And then finally, I think many of us feel like we're holding so many other things together in our lives that we don't have any time for us to enjoy life. But I'm here to tell you, friends, that we were created to enjoy this life also. Yes, we have hard times and we go through challenges, and that's how we grow, but we're also meant to enjoy this world. And I encourage you to carve out even 15 to 20 minutes to engage in some sort of hobby, something that you just do for fun or for pleasure. Okay. So what I would like to do is encourage you. I will be providing to the foundation a handout that they can email to all of you. But what I want your assignment to be is to think about what is the primary weakness or gap in your current self-care plan. And maybe that's that you don't have one. And that's okay. If you don't have a self-care plan, that is fine. We can develop one. But I want you to think, where am I really not doing a good job in taking care of myself proactively? And then I want you, from that previous list, I'm going to put it up one more time for you. I want you to pick 3 strategies that you will try out over the next month. And I want you to pick 3 because you may find that 1 or 2 don't work for you. And I don't want you to be left with nothing. So I want you to try 3 things. It might be deep breathing. It might be gratitude, whatever it is. And then I also want you to write down the names of 2 to 3 people that you can ask to hold you accountable and being proactive about your mental health. Maybe you guys check in with each other once a month and say, hey, how are you doing with, your new strategies? Or maybe you check in once a week. So I'll send this handout out, but if you have access to a phone and you want to take a quick picture of this, please feel free to do that. And then quickly, I'm going to just put up the strategies for prevention one more time. If you want to take a screenshot or take a picture of this for you to do your homework assignment. Now, I know that it's easy to listen to a talk and then go on with your life and think that was such a nice talk, but not really apply it. So I really encourage you, that exercise should take you no more than 2 to 3 minutes. If you don't write down the answers to those things right now, please, before you go to sleep tonight, make a plan. You will be much more likely to start implementing this plan if you think about it now. If you put it off till tomorrow, you're more likely to get busy and to forget. And so with that, I'm going to stop sharing my screen. And I hope this has been a blessing to you. I hope it was helpful information, and I would be delighted to answer some questions.
Thank you so much, Dr. Mercy. Thank you very much. I'll just let you take a cup of water, and I would ask Omon the first question while you take a break. Omon, your camera is off, but I was going to send the first question to you.
I was drinking water.
You were taking water. Okay, that was really loaded is the word. But I'll let her take a break and I'll let her listen to you, Omon, and then I'll start reeling out all the other questions to that. Quickly, Omon, you talked earlier on about, the Nigerian scenario around mental health. I know that some people, there's some questions already in the box about where they can get help in Nigeria for support for mental illnesses. But I want you to talk about avoiding getting help from the wrong places. I know you alluded to spirituality and all of that earlier on. The prof has spoken, it's a combination of many things. Her last slide pointed out the need to also get spiritual support and all of that. But I want you to talk about, because we don't have much time for the questions, maybe you just want to talk about the stigmatization in Nigeria and where and how people can get help and what people must avoid in terms of getting help from the right places. Thank you, Omon.
Okay, thank you so much, Mrs. Komafe. So I think there are a couple of questions in there. I will try and address them. And I tend to use my personal experiences or analogies to try and illustrate things. It makes it easier for me, and I hope easier for other people to understand my what I'm trying to say. When I first wanted to find a therapist in Lagos, somebody referred me to the pastor's wife in my church. And I went to see her, and she prayed with me, and that was it. I mean, it helped. It was nice. It felt good for the moment, but it didn't really do more to address the issues that I was struggling with. And at the time, I didn't even know or understand what I was struggling with. And I needed somebody with, professional training and experience to do that, to help me at that time. I was listening to Dr. Marcy earlier, and there were so many things she said that I personally identified with. I remember when I would not leave my house on a Sunday. So I couldn't even go to church in the first instance. I wouldn't leave my house on a Sunday because on a Sunday was when my stepmom passed away. On a Sunday was when my older brother passed away. On a Sunday was when my dad passed away. And so I had this gloomy feeling every Sunday. And I was so sure that if I went out, something bad would happen that Sunday. Now I don't, well, I do go out, I go to church, I go to brunch. Now for me, and there was something Dr. Marcis also said earlier about the mindset, right? And one of my favorite quotes is, there's nothing that is good or bad, but thinking makes it so. Sunday was like my worst day ever. And now it's the day I look forward to the most because I go to church and then I go to brunch and I can eat carbs. And there are all those beautiful things that I now look forward to on a Sunday because I know that, it was just my anxiety and, and all of that was painting it bad for me. So to answer the question about getting mental health, one of the statistics I quoted earlier is that there are only 300 trained psychiatrists in Nigeria. So of course we know that there's a limit, right? However, there are resources available. I'm happy to share my contact details at the Dew Center. At Dew, we do have trained psychiatrists that people can speak to. The Dew Foundation also supports other mental health initiatives. For instance, we support a 24-hour helpline that people can ring in and it's absolutely free. We support virtual therapy. And so if you cannot afford the hourly rate to see talk therapists, there are group therapy options. There are a lot of options out there. It's limited, but if you look for it and you know where to look, the support is absolutely there. The stigma is real. And I know that, I'm sure Dr. Marcy will also agree that there is some stigma wherever you are in the world. There is some, bit of stigma attached to, seeking help for mental illness. In Nigeria, much, much, much more so. I had a housekeeper who turned out to be, I think she was schizophrenic, and we had to take her back home to be with her family. I couldn't make the trip, so my mom literally took her back to her home, back to her parents. And when she got there, so I remember calling later to check, have they arrived? Is everything okay? When she got there, she found this lady's younger brother chained in the corner of their bedroom. So, again, when we're talking about genetics being, predisposed, etc., and then conditions adding, some of these things run in the families. And in some families, there is too much shame to even admit that there's a problem. There's definitely too much shame to get help. And some people literally chain their parents with dementia, their kids with mental illness. They chain them at home because they don't want them to have to face the rest of the society. What we ended up having to do in that case was to take them, both, at first we thought it was one person we were dealing with. It turned out it was herself and her brother and another brother as well who was on drugs, etc. And we had to take them to a facility in Enugu at the time where they were able to seek help. They probably never even knew that such a facility existed. They probably never even understood what the illness was. And their only solution was to hide in shame and just, deal with these individuals who have a brain illness as if they were animals. So, to summarize, help is there. It's limited, but it's definitely available. I'm happy to point people in the direction if they reach out.
Thank you very much, Amon. Just a quick one before I go to Dr. Marcy. Are there foundations that you are aware of that can offer help for people who can't afford? Because we know that medical support in whatever form is expensive in Nigeria. Are there some foundations supporting such people that you're aware of?
Absolutely. So there's the Dew Foundation that I run. There's She Writes Woman. That also supports, it's called She Writes Woman, but it's actually not only for women. There's Mentally Aware Nigeria and Mani. Those are the three main ones that I know that I've worked with, but I'm sure they're more.
Okay, maybe I'll take the list from you and I will share with everybody who has subscribed for this session. So in case they know someone or anyone around the call needs help. Thank you so much, Amon. Yes, Dr. Masi, I think you have rested enough. I think you've taken enough water. The first question for you, ma'am, somebody says, how do you help someone who is grieving and has grieved more than 6 months? There's so many questions, but this is one that I think I want you to talk about or talk to.
Okay, sure. And I should probably say that I am not licensed to practice medicine in Nigeria, so I can't make any diagnoses. I want to be clear about that. I can't offer any personal medical advice, but in general, there are different ways that people experience grief. I lost my father when I was 19, and there were times that the grief would come back even years later in different ways, different experiences. When I graduated from medical school and he wasn't there, I had a different time of grief. In some ways, everybody is unique in how they experience grief. And so the way you experience it is the way you experience it. So I'm not worried, the 6-month cutoff, that it's not like all of a sudden one day you should not have grief anymore. I become worried when the intensity of the grief is persisting and is not seeming to improve over time, or if it is starting to interfere with your day-to-day functioning, or if the grief is starting to look more like some of those depression symptoms than simple grieving. And we will often call that complicated bereavement or complicated grief, just because it's sort of, persisting. Most of the time, I find that people do very well with getting engaged in some talk therapy, psychotherapy, or counseling resources. Sometimes medication is useful, especially if it's moved into the clinical depression range. But typically, if it's grief, having someone to talk with would be the place to start.
Thank you very much for your answer, and not to worry, we got a warning. We understand that your license covers America.
Yes.
Yes, that's clear. Quick one, there's a question here also that says, can the human brain as an organ be damaged through depression beyond recovery? I think you had a chart earlier on of MRI of the brain. I think the question is, can the brain be damaged beyond recovery?
That's an interesting question. I don't think I've ever had it worded that way to me. There are some mental health conditions that we know, if left untreated, can be, for lack of a better term, toxic to the brain. You can see neuronal loss, brain cell loss. I don't believe that depression has been associated with that. Most of the time, people are able to recover from depression. Sometimes people experience chronic depression and they may need more intensive treatments, or they may have depression that's what we call treatment resistant. It's difficult to control. But again, doing the combination treatments, usually people can find some relief, even if it doesn't go all the way back to normal. I don't generally think of depression as being one of the kinds of disorders that can have permanent damage to the brain.
Thank you very much, Dr. Masi. I think that is clear. We have a cluster of teachers around the call because, this webinar is in honor of the teachers that we're celebrating and that we're choosing to acknowledge at this time. I want to narrow the question down to the age band of students in colleges. Maybe let's take 9 to 16. I think that's the age now where they get into college. I wanted to help parents around the call and teachers alike on signs. I know your slides are very detailed and very comprehensive, but I want you to break it down to help the teachers and the parents around the call. What are the signs that we as parents and teachers should watch out for in children of that age, I think for adults, like Omon has explained, and things you showed earlier on, we know when things begin to go down south and all of that. But for the young ones, what should the teachers around the call watch out for? Bearing in mind the peculiarity of Nigeria that we are in.
Sure, absolutely. And I specialize in adults. I have done a little bit of work with children, but what I typically look for is change in behavior, something that is different than their normal. And the challenge is that sometimes it's subtle. It begins slowly, but if you pay attention and say, let me give an analogy. When children are growing, if you look at them every day, you don't see them growing, right? But if you look at a picture and then look, a year later at another picture, you're like, oh my gosh, that child has grown so much. So there's a lot of change that can happen that you realize sometimes upon reflecting back. So when you look and you realize that someone's academics have dropped off, somebody who may have been doing well academically is all of a sudden not, someone who is turning in homework all of a sudden is not, that could be a warning sign that something is not going well. If there's a change in their behavior, they become much less outgoing, or they were usually very shy and now all of a sudden they're almost inappropriately outgoing. That could be a warning that there's something going wrong. Isolation could be a concern if they tend to want to spend all of their time alone. Now, I don't know in your culture how, cultural context, how this applies. Teenagers here, in their teens, they tend to like spend a lot of time in their room, but that's not the same as wanting to isolate and be alone all of the time. If you see changes in their friendships, impact in sleep and appetite, those are definitely things that I would be concerned about as signaling challenges.
Thank you very much, Prof. I think this next question would interest you, especially as you're in the academics. So there's this student who says, I'm a student in a higher institution in Nigeria. Stress and workload is terrific. We are mostly overwhelmed with assignments, especially during exams like this period. And then he goes on to say what he does and what he doesn't do to help himself. So the question will be, how can we differentiate normal academic work pressure from a pressure that is, identified with mental illness?
Sure, absolutely. So yeah, that's very common. And I think, a lot of students in your situation would have the same kind of anxiety and stress with that high workload. I certainly did when I was doing my studies. I can agree, and I empathize with you, and I wish you the best of luck with all of your exams. Often, so I work with a lot of medical students here, and what I note, one of the things that I notice commonly when they are starting to move just from having a lot of pressure into having anxiety or depression is they will come to me and say, my studying isn't working anymore. I feel like I'm having to read the same thing over and over and it's not going in. I'm studying for 3 hours and I'm not retaining any of it. And that's really the problem with concentration. So when your concentration changes, then that could be a signal. But again, I would look at what, when you get through the exams, are you back to normal? Because if you have a real mental health challenge like depression, just being through the exams will not all of a sudden magically make your depression go away, right? Or now if you have a real anxiety disorder, you get through the exams and now you'll just find something else to be anxious about. So again, thinking about the intensity, the severity and persistence, the associated signs and symptoms, like it, when you're studying a lot, you might not be giving yourself enough time to sleep, but when you do try to sleep, are you able to fall asleep? Are you able to stay asleep? How is your appetite? Those kinds of things.
Thank you very much, Prof. There's a very funny question here. I've been smiling, and but it's your question. There's a question for you, so you would have to answer it. And before I go to that, thank you, sir, Professor Ogunbolade, for the link. He sent us a link to an NGO that will offer help, and I will share it with everybody via email. So, Prof, somebody says, is there any connection with menopausal symptoms and depression in middle-aged women? And if anyone on the call has gone through menopause.
Yes, there has been some association with that, certainly. And there are some people who find that they do better when they address some of the hormonal imbalances. Absolutely, there can be an association. Again, it's not across the board. It's not that everyone who goes through menopause will develop mental health symptoms, but sometimes that can be a triggering episode for it. Again, our whole body is connected. So when there are other things going on, other illnesses going on, menopause isn't really an illness, but other changes in our hormones and our body chemistry, it can affect our mental health as well. And just to give a further example of that, when I'm treating somebody when I think they have depression, I've diagnosed them with depression, I like to always order blood work to make sure that they don't also have a problem with their thyroid or with anemia, a low blood count, because both of those things can mimic depression. And so it's important that, we make sure that you're physically healthy. Again, I'm going to say mental health concerns are really physical concerns because it's a brain disease, but we want to make sure that your body is doing well in addition to the mental health symptoms.
Thank you, Prof. Thank you very much. This next one is a little bit long. I would read it because I want you to speak to the question. Madam Rabi says, I read in a medical journal that antidepressants only work about 60% of the time. And I read in the small print of some antidepressants online that they can cause suicidal risk, particularly in young people, and that they work by inhibiting aspects of brain work related to innovation and creativity. I would like to hear the doctor's views.
Yeah, so it depends on the studies that you read, but they are not 100%, each antidepressant is not 100% effective for every single person that takes them. That's true about most medications, right? If we look at medications across the board, sometimes, if you prescribe, a medicine for blood pressure, it may not work for a given patient, and you may have to try a different medicine. That is absolutely true about antidepressants. So we know that they all have been shown to work. The question is, will it work for you? And, will this particular one that we're trying work for you? So yes, it's not 100% across the board. I personally like it best when people do the talk therapy as well as medication if they're going to take medication, because I want to see both of those things together. The question about suicidal thoughts, you are correct that there is a black box warning, is what we call it in this country, meaning that it's just something that they highlight for a specific age. So generally, teenagers, younger individuals, and very young adulthood, slight increase in suicidal risk. I will tell you, a greater risk for suicide, in my personal opinion, is untreated depression. That is 100, we know that untreated depression is definitely associated with suicidal risk. There's a slight increased risk with taking an antidepressant if you're in the younger age group. Now, we don't fully understand exactly why that is. There have been different hypotheses, different things suggested for why that might be. I remember hearing one possible reason why that could be is because one of the first symptoms to improve is your energy level and your motivation. But you might still be feeling very depressed. So you may have been depressed and having suicidal thoughts, but low motivation and energy. And now you still feel depressed and suicidal, but the energy has improved. And now you are more likely to take action. So we still use them in that age group. We just follow much more closely. We educate, we say, listen, if you have any thoughts of suicidal thinking, please let me know right away. And then we just follow them much more closely to make sure they're okay. And then I think the last part of that question had to do with creativity. I have never seen that study. I'm not saying that it doesn't exist. Maybe there is a study that says people take it are less likely to be innovative and creative. I actually, though, find that most of my patients are much more productive once they have the veil of depression lifted, because now they have motivation, they have energy to do the things that they want to do. Could there be somebody who feels like they're, and you can always find one person who experiences, an unusual response to something. So maybe that has happened to some people, but I have not witnessed it in over 20 years of being a psychiatrist.
Thank you very much, Dr. Mercy. Thank you. I'm sure you've noticed I'm calling you prof, I'm calling you doctor in between, because Admiral Kamalafia and I had, I don't know if it's a competition of what we should call you. He says he will call you prof, and I said I will call you Dr. Mercy. So behind my brain, I have him telling me to call you prof when I do. Thank you very much.
I answer to any of those. It's fine.
Thank you
it's
very
fine.
much. I'll let you take a break, and I'll take there's so many questions, by text and in the Q&A box, and some in the comment, the chat box. We can't answer all the questions, but I'm gonna plead with you that I will do a collation of questions, and you can, I will send them to you by email, and the responses that you send to me, I will share with the people who have asked the questions. Let you take a break while I come back to Madam Omon. Omon, this one, I thank you so much. Anyway, you have a Western upbringing, so you're not a core Nigerian, but I can see that the ease with which you've been able to share with us. Now, seriously, not many people would put themselves out there and say, "Look, I've been through this in Nigeria," but because you have exposure beyond that to understand that health first before anything anybody can think about. I want you to wrap up the session today for us with the symptoms that you saw that made you know that something is wrong. I mean, you are very, very successful interior decorator. You're well sought after, jobs here and there, so you were not lacking in any way, but you just knew that there was something wrong. And when we spoke yesterday, you said you actually physically went to a facility for treatment. Please tell the people around the call, because we do have professionals around the call who wake up, you know how it is in Lagos, a hectic thing. Everybody just jumps on the road to look for Naira or to look for dollar, and then we're not taking care of mental health. Please tell us maybe 2-3 signs that you saw that said to you, I have to slow down.
Only 2-3. there were many, but the first sign that actually got me to take action, right? Because everything else I explained away and I accepted as normal, was a pain in my lower back that doctors in Nigeria and abroad could not explain. MRIs could not find anything physically wrong with me. And then I was asked to actually observe and journal and notice when I felt the pain, what triggered it, what caused it, what led up to it, etc. And I realized that it was when I was stressed, when I was tense, when I'd come towards the end of a project, and there's just all this pressure, and then my back begins to hurt. And it's not really because I've done any physical activity. I was this close to having surgery on my spine. Anyway, long story short, it was just my body's way of telling me that something was wrong. So that was the one thing that pushed me to take action. And then in hindsight, I'm beginning to, I began to understand other things that I now know were symptoms that I didn't understand then. The low moods for no apparent reason. Nothing's wrong. You're happy. There's money in your account. You have food to eat. You've got projects. What's wrong with you? Why are you sad? And I couldn't explain what the sadness was about. And then there was the guilt for feeling sad, because really there's nothing wrong with you, so why are you sad? And it was just, I can't remember the word Dr. Darcy used, but it was just over catastrophizing. Is that a word? What was the word?
Yes.
Situation.
That's a new one.
Right? So I heard a story. I didn't even know the person. I heard a story about somebody in Lagos who fell into a gutter and drowned. He went out at night, he fell into a gutter. And then every night I was so sure that my husband was in a gutter somewhere. Like, I was just so sure, right? And there was no reason. So just having these thoughts and just taking things to extreme, and there was no logical reason why you're thinking that way.
Yeah.
So, you know, it was things like that. The biggest thing really was the low mood. And then there was the physical pain and tension in my body that I could feel, the headaches, the lower back pain and things like that, when there was nothing, you know, I don't know, medically, physically wrong with me. You asked for 2 or 3, there were more, but I'll stop there.
Yeah, we don't have time. Thank you so much, Omo. I thank you is not enough to thank you and Dr. Mercy for this session. The comments in the chat box already says that we were right to choose the topic, and we were also right to choose the speakers, the resources. I want to thank you both very much for your time and for sharing with us from your wealth of knowledge. Thank you so very much. We promised 1.5 hours, but we're way beyond that. Also at this time, I would like to thank all the participants, especially the educators, the teachers around the call. I thank you so very much for joining us, especially those that signed up way before the 5 p.m. Thank you very much. We honor teachers, we honor educators, and Rehoboth is very proud to celebrate teachers and educators in Nigeria. Tomorrow we would be having the 2022 Teachers Excellence Award, where we would be honoring 3 teachers nominated by the students and by their local government areas. I would also like to thank all the financial sponsors. I would like to thank the volunteers. There's some people around the call who work with Rehoboth for no payment, no salary. They take their time to help us with the screening of students and you know, doing so many things. Thank you very much. To the staff, you know, this is our thing. Thank you very much. I know you get paid for this, but if you don't do it well, then there's a problem. So thank you very much, the staff. And I would also like to thank the friends of the chairperson, the chairman of the Board of Trustees, Rear Admiral Dende Joseph. He has so many friends around the call from the military, and friends of one of our trustees as well, friends of Admiral Komolafe. Thank you very much to all the senior naval officers who joined in. And thank you to all the members that came from the education sector of the Nigerian Navy. Thank you very much. Special thank you to those giving us press coverage. Thank you very much. We know we'll see you tomorrow. And we have a mama and a grandmother in the house. I'm not going to finish this call without celebrating Mrs. Margaret Koshoni. She is a grandmother, and she joined us this evening. She is a mentor, and there are so many things to call her. I saw that she put in, and she said she's a senior citizen of Nigeria. And I said, that's good, because she's over 80. Thank you so much, Ma, for joining us. And to every person, to all the trustees that joined from very far away, our trustees in Australia. Thank you so much, Pastor Joshua, Pastor Yinka, for introducing Dr. Mercy to us. Thank you very much. I can go on and on. If I didn't call your name, know that we thank you all the same. I am very grateful. On behalf of the chairman, Board of Trustees, I say thank you very much to you all. Pastor Jay, I can see you now. Thank you, Dr. Mercy. Thank you, Omo. I am really grateful. And thank you, ladies and gentlemen around the call. All my friends around the call, I see you, Auntie Sophie, I see you, Mama Spain. I see all of you. Thank you very, very much. Madam Rabi, thank you, Metro family. Thank you so much. Dr. Mercy, I'm going to get in touch with you for the slides.
Yes.
Thank you very much.
I'd be happy to share those by email, and I'll also send you the exercise.
Yes. When you said you're not going to let us go free without giving us assignment, I said, once a teacher, always a teacher, right?
Yes. It's true. And for all of the teachers on, I used to be a high school teacher as well before I went to medical school and became a doctor.
We're going to have a physical session tomorrow where we would celebrate the winners of the award for this year.
Wonderful. And I just want to thank you for sponsoring a session like this. I think it's so important. And thank you for all the amazing work that it's clear that you're doing with the foundation. I'm so impressed with everything that you guys have done. And thank you. Thank you to everybody who made the tech work also. I really appreciate it.
Yes, indeed. To the team that made the tech work. Yeah. Thank you, Dr. Massey. It's an
Dr. Massey,
yes, Omo, after you, please. Yes.
Sorry, ma. I was just going to say that I'm actually really quite looking forward to receiving the slides as well, because, you know, as much as I thought I knew about this subject, I've literally been scribbling the last hour. I've learned so much today, and, you know, I'm really excited. And the way you presented it was just so clear and so simple and easy to understand. So that was beautiful as well.
Thank you.
Last thing that I wanted to say, Ms. Komlafa, you commented about me being open and sharing, and maybe it is my Western education, but also I do think that it's very much about my personal experiences. And I know, you know, they say people perish for lack of knowledge, and I found that I suffered so much unnecessarily when I didn't know.
Because you did not know.
I didn't know what was going on, and I didn't know that other people were feeling what I was feeling. And there's definitely that relief just in knowing that you're not alone, and this thing that is doing you, there's a solution to it. And you know, you're not flawed, you're not faulty, you're not, do you know what I mean? Like you know, it's an illness just like any other, and you can get help. So I talk about it probably too much. Like I'm so happy.
It's fine. It's
talk
fine.
About it
because you want others to get help.
I feel like it's one person. Absolutely.
Yeah. It's just like Rehoboth, you know what our slogan is? We say little drops, big changes. So if it's one person that we can impact, we know that we're impacting somehow. And so, you know, when you share your story with the Dew Center, you know, one or two people, and honestly, if it's only one person out of all the almost 300 people that listen to you and Prof this evening,
then it's worth it.
Seek help, then we have done something. And, you know, we got help, you know, the former Vice Chancellor of the University of Ife, which is now called Obafemi Awolowo University.
My mom went to Ife.
Sorry, you went to Ife, or your mom?
My mom went to Ife.
Okay, so he shared already a resource, you know, a free foundation where people can get help. I'm going to add that to the three that you listed earlier on. So who knows? You know, some people like to talk to people that are not near them, you know, that wouldn't know, you know, because of the stigma, whatever it is in Nigeria, you know. So if it's only one person that gets better, then we have done something. We have done something, So thank you very much. Thank you very, very much. Have a good evening.